maybe we can go to the next slide and get started here. So welcome to the Living Cardiovascular Institute. As you just saw on the welcome slide, we are an institute working to connect cardiovascular research, education, and clinical care. And tonight you're joining us for our Sleeping Well session, and it's examining the links between sleep and cardiovascular health. Up to the next session. At the Living Cardiovascular Institute, we do many things. We have several programs that are designed to do what I just said. So bridging cardiovascular health research, education, and care. We have our women program, which is the CV and Me Women Cardiovascular Health Research Initiative that has the goal to transform the future of women cardiovascular health through health research, training, and care. We have also the P2 Person to Population Cardiovascular Research Collaborative Group, whose mandate is, which is a multidisciplinary platform with the goal to foster research on precision population cardiovascular health. And the goal of this group is to increase awareness about the impact of what we call social determinant of health on cardiovascular care, enhance personalized cardiovascular care, improve collaboration among scientists in Calgary, in Alberta rather, and improve cardiovascular health in the population in general. We also have a group called the Stevenson Cardiac Imaging Center, and this center is one of the leading clinical research and teaching programs with the focus in the field of personalized cardiovascular care delivery. And finally, we have a data initiative group, which is designed to improve patient outcomes by improving cardiovascular data for use in the clinical decision-making and research. So lots going on here at the Living Cardiovascular Institute. You can go to the next slide. So for those of you who are joining us on Calgary, we would like to take some moment to acknowledge the territories we are speaking from, and most of us are in Calgary. So I would like to acknowledge that the traditional territory of the people of the Treaty 7 region in southern Alberta, which include the Blackfoot Confederacy, comprising of the Siksika, the Piikani, the Kainai First Nation, as well as the Tsuut'ina First Nation, and the Snowy Dakota, including the Chiniki, the Bearspaw, the Wesley First Nation. And the city of Calgary is home to the Métis Nation of Alberta, Region 3. Up to the next slide. So a little bit of housekeeping. So as I said earlier, don't feel pressure to share your screen. We want you to feel comfortable, but we would like you to make sure that you remain on mute throughout the presentation portion until the question and answer period, where you'll be free to to unmute at that time and share your questions. Also, because this involves some medical information, we want you to be mindful of sharing your personal information, because this is a public event, and also the event is being recorded. So just be careful about what you share. Next slide, please. So I'm here also to remind you quickly that right now we are in the middle of what we call Living Moves and Move to Improve initiative, and it's initiative with the goal to encourage adults to meet the minimum of 150 minutes of moderate to strenuous physical activity each week for optimal cardiovascular health. So we offer a lot of free resources, which include some live and pre-recorded fitness classes, workout scheduling software, and we had a lot of fun prize earlier in the campaign to help you keep motivated. So we are already close to the end now, but if you are still, you're still part of the campaign, we encourage you to keep going strong, and if you fall off the wagon, pick it up again and keep going. And we want to move together. We want to have optimal health together. So if you go to the next slide. So we have some upcoming events for you to attend. We have on Mother's Day, the Sexy Mama Dance class. So, you can always join us and, learn some really fun move as you with your mom or with your daughter. We have also next week the Heart and Mind Mental Health for Heart Disease Patients. And also we have on May 8th, the Grow Your Way to Better Health. So lots of events, lot of things happening, and please join us at one of them. You can find more information by visiting the website of Living Moves that's here, and always reach out if you have any questions. Okay, next slide. And more on that subject, please tag us if you are sharing some moves out there. Hashtag Living Moves. That's Living Moves. Whether it's you and your grandkids and doing some movement out there, walking, enjoying, the weather. Please tag us. We want to see you and we want to see how you're moving. Okay, next slide. Okay, so it's our pleasure right now to introduce Dr. Manns and Dr. Marcus Povis. I should have practiced. Megan, you can stop sharing your screen, and then I don't know if you have Marcus slides, but
so Dr. Povis, you can just screen share your co-host right now. So on the bottom, there should be a green button that says share your screen, and you can share your own slides. Great, thank you.
Yes, and just...
Can you guys see the slides now?
Yep.
Yes, we can see the slides. And yes, so Dr. Marcus, I'm going to call you Marcus because I don't want to butcher your last name.
That's okay.
Is a postdoctoral. So Marcus is a clinical assistant professor, and we are very proud to have him here and very honored. So Dr. Marcus, the floor is yours. Please go ahead and get started.
Okay, thank you very much. I just wanted to thank the organizers for this opportunity to speak about a very important topic, and to the rest of you, thank you for attending and for your interest. So as mentioned, I'm a clinical assistant professor at the University of Calgary, and I work at the Foothills Hospital at the Sleep Center there. We've already done the territory acknowledgement. I have a few disclosures to make just in terms of some potential conflicts of interest I don't think should have any bearing on the talk today. I do read home sleep apnea tests, and I have accepted consultation fees from pharmaceutical and technology companies. So today what we're going to discuss to start is a little bit of an overview about normal sleep for adults, and discuss the relationship between sleep and cardiovascular disease and health. And then just to finish up, I'll talk about a few specific sleep disorders or common sleep disorders you all have likely heard of, and discuss some of the cardiovascular outcomes in those areas. So all of you would be aware, humans spend about 1/3 of their lives sleeping. You shouldn't think of sleep as just the absence of wakefulness. It actually has a very useful function. And there are many brain pathways not used during wakefulness that are activated during sleep. In addition, it's a period of energy conservation, of slowed metabolism. There's increased parasympathetic nervous system activation, and there's an important role for cellular repair. So our drive for sleep is driven by internal clocks. Our bodies actually have internal mechanisms that function like clocks. And there's external stimuli such as light, meal times, and exercise, which help to control these and keep us on a regular schedule. Things like how long we've been awake and how bored we are can make us feel sleepy. And these can be further modified by things that we take in, caffeine being probably the most common stimulant that people take. But there are other examples like amphetamines or derivatives thereof that people may be prescribed for a variety of disorders. And there are many depressant medications, things like sedatives, antidepressants, as well as recreational substances that people take that can also make them feel sleepy. This is just a graphical representation of what I was saying. So during the day, we have our circadian alerting signals. Circadian refers to our internal clock. And as the day goes on, the circadian drive actually increases, and this is what allows us to stay awake throughout the day. And as evening comes on, the circadian drive starts to wear off, and then it comes back up again the next morning. At the same time, we have sleep load or sleep drive, which largely relates, like I said, to how long we've been awake and what we're doing. And so that increases steadily over the day and eventually supersedes the circadian alerting signals, and then we're able to sleep. And oftentimes when people sleep poorly, it's because of disruption in these two things, trying to sleep at the wrong time, or because people don't have healthy habits that help them to maintain their circadian rhythm that would allow them to sleep normally. So sleep is divided into stages. Many of you would have heard about the idea of different types of sleep. There's different electroencephalographic findings, different electrical activity in the brain that corresponds to different types of sleep. There's light sleep where we see theta pattern. There's stage 2 sleep where we see sleep spindles, slow wave sleep or delta wave sleep, which are more common as a restorative, regenerative type of sleep. And then there's paradoxical or REM sleep where we're dreaming and our brain activity resembles wakefulness, but our bodies are relatively paralyzed. And so there are different degrees of muscle relaxation in these types of sleep and different difficulty in the ability of others to rouse us or different stimuli to rouse us. And gradually with those, there's differences in respiratory effort, with the least effort being seen during REM sleep. And we all go through REM and non-REM sleep in periods of between 90 and 120 minute cycles. And it's not only getting the different sleep stages that's important, it's also having the sleep cycles and having continuous sleep for longer periods of time that has been shown to be helpful. This is just some graphics to illustrate what some types of sleep appear like. These are from individuals who are going through sleep studies to give you some idea of why sleep in these might be a little bit disrupted. And so this first individual you see stays awake for the first hour or so, then falls asleep, and you can see they cycle through REM, and then they're back into lighter sleep, then back into REM, and this goes on over the night. The second individual has less of that period of wakefulness and a more normal rhythm where their sleep, their REM periods get longer and longer. And usually the longest REM is seen closest to the morning. And then the last person really didn't sleep well in the sleep lab environment. You can see they were awake, they have fragmented sleep, particularly over here in the early morning hours, before they finally get back to sleep and have some deeper sleep. So the question then arises, how much sleep do we actually need? And over time, there's been recording that the relative amount of sleep that people are getting has varied. There was a belief held by the research community in sleep medicine that in modern times, people tend to get less sleep than in historical or traditional societies. And one of the more famous sleep researchers, Jerome Siegel, actually studied some traditional hunter-gatherer societies and found that similar to today's societies, if given the opportunity, people will try to avoid sleep. And so since the advent of artificial light and electricity, people have been able to stay awake longer by entertaining themselves or taking advantage of artificial light. That said, there's also a relationship between social deprivation and poor sleep or less sleep. But many of you would recognize that we watch television, we use the internet or smartphones, all of which have bright light and deliver stimulating content, which then disrupts our sleep further. So there's a famous statement, and I don't know who to attribute it to, but that artificial light may be hazardous to our health. And that's because you don't get enough sleep. This slide is courtesy of the National Sleep Foundation. It just outlines how the length of healthy sleep varies over the life cycle. And so I don't think I saw any newborns or infants on the list of attendees, but so most of us are probably between the young adult and the older adult. And so a rule of thumb is somewhere between 7 and 9 hours is considered a healthy amount of sleep. And as people get older, they may need less sleep or be able to sustain less sleep. And so they have done some studies where they assess large populations of community dwelling individuals and ask them how long did they sleep for, and try to correlate that to some health outcomes. And interestingly, there is an increase in cardiovascular disease and mortality, both in those with shorter sleeps and with longer sleeps. And shorter sleep has actually been correlated to many other findings, such as obesity, cardiovascular disease, diabetes, and many other conditions. And the mechanism's not entirely clear, though, as I mentioned, sleep is opportunity for metabolic slowing. And so people may eat differently if they stay up too late. They may not conserve energy in the same way. There may also be disruption of certain important hormones, neurohormones that protect us from some of these conditions. On the flip side, longer sleep is not seen very commonly. And as my own supposition is that people who spend a lot of time in bed, usually it's because they're ill. Either they have medical illness or they take medications. And it's likely those conditions that associate with cardiovascular disease more so than the long sleep itself. So just some statements in summary. Healthy sleep is important for homeostasis, or the body's maintenance. And sleep needs to be prioritized as part of a healthy lifestyle. The notion that prioritizing sleep should be associated with laziness or things like that should be disregarded. On the other hand, people who have short sleep or long sleep, these can be markers or causes for cardiovascular health risk. And it's important to note that humans do not adapt to short sleep periods. If you try to force yourself to sleep less than the recommended time or what is healthy for you, then you're likely to find yourself having continued sleep debt even after a long period. What am I doing for time? So just a couple of quick slides. So many of you would have heard about sleep apnea or obstructive sleep apnea. I'm just going to comment on a couple of associations with that condition briefly. And so obstructive sleep apnea, what that is intermittent collapse of the airway, which leads to sleep fragmentation because of the difficulty with breathing and drops in the oxygen level. And this has been shown to be associated with things like oxygen-free radicals, and increase in stress hormone levels. And the main risk factors are obesity and older age. And in some studies, there's been suggestion that up to 25 to 50% of middle-aged adults have sleep apnea of some severity. We score the severity based on how many times per hour there's a breathing disruption. Skip that slide. But so just to illustrate what happens is that the palate is falling back, or the tongue and the palate are occluding the airway. And this happens recurrently during sleep because of changes in muscle tone and drive to breathe. So this is a famous study, perhaps the most cited study in sleep medicine, done by a group of Spanish researchers, where they looked at individuals who had sleep apnea from their clinics. And they broke them down into people who didn't have sleep apnea, people who snored, people who had mild sleep apnea, people who had severe sleep apnea, or people who were treated for sleep apnea. And on the left side of your screen, you have the fatal events, and on the right side, you have the non-fatal cardiovascular events. And both of these show rather dramatically the potential risk of having sleep apnea and not using Cpap treatment. Unfortunately, that sort of data hasn't been borne out in follow-up studies. So there was a large randomized controlled trial that was completed about 5 years ago, I want to say, called the SAVE study. And this was a study, had certain methodological issues that I won't get into, but basically randomized individuals who had severe sleep apnea without severe daytime sleepiness to Cpap or to observation. And what the study found was that there was no difference. And the explanation that the authors provide is that the average individual using Cpap in the study didn't use it enough. So what we've still continued to think is that people who use Cpap may have better cardiovascular outcomes. However, Cpap on its own may be an inadequate treatment because so many people can't tolerate it or choose not to use it. And so there may be a role for other treatments such as dental appliances or surgical treatment. The other issue is that people who don't use Cpap may differ in other ways. They may not take their medications or follow doctor's advice or have other unhealthy habits that prevent them from using Cpap. The last comment I'll make is about atrial fibrillation. This is an editorial I wrote with Tim Pollock, who I don't know if you've had on this venue before, but he loves to talk about atrial fibrillation and antiarrhythmics. But there is a longstanding association between OSA and atrial fibrillation. They have many common risk factors, things like age, obesity, and hypertension. And in some studies looking at treatments of atrial fibrillation, sleep apnea has been associated with treatment failure. What we found, what we wrote that editorial about was that it tends to be that clinicians don't think about sleep apnea until much too late, and that clinical markers alone are inadequate to assess for sleep apnea. You really need an overnight test to know whether you have sleep apnea or not. To date, however, we don't have a study that indicates that sleep apnea treatment with Cpap actually improves outcomes, and so that is something that we really need to push forward on. So I think other things that might be interesting to look at from a research perspective is looking at lifestyle interventions, because healthy sleep is so important for cardiovascular health and weight maintenance. And looking at alternative treatments of sleep apnea other than Cpap, as well as studying other cardiovascular diseases where sleep apnea may be contributors, such as diastolic heart failure, diastolic dysfunction. That's all my slides.
All right, thanks so much. So we're actually just going to move straight on to Dr. Manns, and Camelia can do the introduction there.
Yes, I just had an issue with my computer earlier, but I wanted to say thank you so much, Dr. Marcus, for this presentation. And just to give everybody a quick overview of his accomplishment as a researcher and medical professional. So Dr. Marcus is a respirologist and sleep disorder specialist and a researcher affiliated with the University of Calgary. He trained in respirology at the University of McGill, and he's completed several fellowships, including in sleep disorder medicine at the University of Calgary. He completed a master's degree in community health sciences at the University of Calgary, so University of Calgary alumni for sure. And his focus was on health service research. He also completed a fellowship at Western University in health administrative data and research. And his clinical interest, as you saw it, is in sleep medicine and respiratory failure. So really knowledgeable, and his clinical work is continuing, and he's involved right now in clinical research in the area of sleep disorder briefing and health service delivery for obstetric sleep apnea. So if you have any question about that, we will take a short question and answer period at the end of the presentation. So please write your question in the chat, and then we'll address them after Dr. Braden's presentation. So Dr. Braden is a professor in health economics, a kidney specialist at the University of Calgary, and the associate chief medical officer for the Alberta Health Services Strategic Clinical Network. He's also has experience in the pharmaceutical industry, and which include a chair of Canadian Expert Drug Advisory Committee and patient-oriented research. His research experience is in applied health economics, and his current research interests include examining the implication of patients-borne costs on care and outcomes in chronic diseases, examining the cost effectiveness of healthcare policies for managing patients with chronic diseases, and assessing the implication of different ways to pay physicians. So really a knowledgeable professional as well today joining us. And he's going to speak to us about restless leg syndrome and what it is and how it can be managed. So off to you, Dr. Braden.
Thanks very much. So I'll share my screen as well. I know a few of the individuals attending. Can you see my screen?
Yep, all good.
Excellent. Okay, so I'll just. So I wanted to start off with actually a couple of stories from a few people I've seen and talked to in the past week. So the first individual, I was doing dialysis rounds. She's a lady in her 50s. She's on dialysis. She's got a history of heart disease. And she was complaining that night about her legs being kind of jumpy, like she needed to move them. It was bothering her in the evenings. Oftentimes it really bothered her when she was on dialysis because she had to sit there not moving for a while. She had this urge she needed to get up and walk, and it was affecting her sleep. And she was wondering about potentially medications for this. So we started talking about that, and maybe we'll visit her at the end. I also got a call from a patient who was not yet on dialysis. He had mild kidney disease, and his wife had noted that he kept moving his legs constantly at night, sort of in a rhythmic pattern. Every 15 or 20 seconds, he would move his legs. And interestingly, it didn't bother him. He slept fine, but it bothered his wife, who needed to eventually sleep in a different bed. So keep these in mind, because understanding what is and what isn't restless leg syndrome is important. Although Camelia asked me to do this talk because we're running a study randomizing people to different types of treatment. The study's run out of Hamilton. I'm not an expert in restless legs. I look after people with kidney problems, but people with kidney problems often get restless legs. So what is it? Well, one simple screening question has been identified as pretty accurate. So do you answer yes or no to this question? So when you try to relax in the evening or sleep at night, do you ever have unpleasant, restless feelings in your legs that can be made better by getting up and walking or by movement? So if you answer yes to that, there's probably about a 75% chance that you might have restless legs. So the actual official definition, and just look at the bolded text, it's an urge to move the legs, and it's usually accompanied by, this is uncomfortable and unpleasant for people. So it's an urge to move the legs when you're resting or when you're inactive. You're watching television, you're on dialysis, you're in bed. It's made better by movement. So if you get up and move, that usually makes it better. It's usually worse in the evening or night. It's not usually a thing that happens in the morning or the afternoon. And it's not accounted for by some other health condition. So you have to have all 5 of these to be considered having restless legs. So about 5 to 10% of the general population, when you do surveys, would fit the criteria for restless leg syndrome. Not everybody would want or need any treatment. Maybe 2% of people have moderate or severe symptoms, and they're looking for suggestions and advice. As with most things in medicine, there's many factors that go into this. So when you test people's DNA or their genetic code, we can find some differences that commonly are associated with restless legs. It's not like if you find it, they definitely have it, but they're a little more likely to have it. About 60% of people will say they have a family history. Interestingly, people who are deficient in iron are more likely to have it. So there seems to be that iron deficiency is somehow important. And then dopamine pathways, signalers in the brain, are also important. And we know that people who have nerve problems in their peripheral nerves, so the ones in their legs and their arms, if they have nerve problems like from diabetes or other things, they're more likely to have this. So the first thing that in that second case, many people with restless legs also have what's called periodic limb movements at night. These happen when people move their legs. About 90% of people with restless legs have these, but in fact, it's not part of the diagnostic criteria. So having legs that move at night doesn't mean you have restless legs. People with restless legs often have difficulty sleeping though, and it impacts their quality of life. So there's a very strong association. Nearly 25 to 35% of people with iron deficiency will have restless legs. And anywhere from 15 to 65% of people with kidney failure on dialysis will have restless legs. And Camelia asked me to do this talk in part because restless legs are relatively common in people with heart conditions or stroke or high blood pressure. But before I went into presentation mode, I saw somebody ask the question, do sleep conditions cause heart disease or is it the other direction? And the same question is probably appropriate to be asked here. Actually, probably restless legs, possibly because you don't sleep as well, possibly because if you don't sleep as well, your blood pressure is a bit higher. That actually may make you at higher risk for developing heart problems or strokes in the future. So there's lots that you can do without going into medications. So limiting caffeine and alcohol, stopping smoking, though it's an addiction, so that's hard. Being physically active, so riding a bike or walking, aerobic exercise or resistance training is helpful. Stretching your legs, massaging your legs before you go to bed, a warm towel or a heating pad, or a bath. And if warmth doesn't help, sometimes people find if it's their lower legs that they put a cold compress on their lower legs, that helps. So patients often want to know what testing is required. When in fact, really almost no testing. We'd suggest that everybody get a blood test to see if they're iron deficient. But really, this is a clinical diagnosis. If you answer those 4 questions we had, you don't need x-rays, you don't need other imaging, unless it's sort of an atypical case. So how do we gauge whether people need medicines? Well, there's a series of 10 questions. I put the first 2 here, but how would you rate RLS's restless leg? So how would you rate it? Is it very severe, severe, moderate? How would you rate the need to move around because of your restless legs? And they have questions around frequency and things. And if you score those up, the scale is out of 40. And if you're over 15, generally that means people are quite bothered by it. So what about medications? So if your iron levels are low and you replace the iron, 20% of people are cured. There's an improvement in others, but it only works if you're not iron deficient. Iron doesn't help. The part about other drugs is they can be effective, but they can have side effects and they need to be carefully watched. So we're not going to go through them, but the common ones we would start with would be things like gabapentin and pregabalin, which are used often in neuropathy, but they have side effects at higher doses. And then because dopamine is important, things that either stimulate the dopamine system, like levodopa at the bottom, or augment it, like pramipexole, are used as well. But there's lots of side effects, and augmentation is actually that the condition can get worse as you start introducing these pills. And that's very common with some of these pills, and you have to be very careful as you're, so that's why these aren't over the counter. So what else to consider? Well, if you have restless leg syndrome, as I say, it's only if it's more common in people with heart disease, it's only slightly more common. And actually, it's probably the other direction, that people with very severe restless leg syndrome can be at higher risk of developing heart attacks or strokes. And so getting your risk factors for heart attack and stroke checked, your weight, smoking, diabetes, high cholesterol, family history, and your doctor should be talking to you about those, because there's a lot of effective treatments, including lifestyle changes, that can prevent heart attacks and strokes. So restless legs are common. It can be partly genetics, partly iron deficiency, severe kidney disease. There is a relationship with heart disease and stroke, but it's maybe not in the direction that you initially think. Many people improve with non-drug treatments, and there are drugs available, but they need careful titration. And if you do have it, getting yourself checked for blood pressure and other risk factors would be important. So I'll stop there.
All right, thank you so much, Dr. Manns. And I think we're going to move over to some question and answer. So Dr. Povis, we're also going to ask you to jump in. If any of the participants do have questions, please just type them into the chat box, either directly to me, so Lauren Drogas, or you can type them to everybody and I will moderate to see who is going to be answering these questions. So for right now, the first question that I've got, let's see. So there are a couple questions about specific of, is this enough sleep for a person of this age? I think at the end, we'll probably ask Dr. Povis to generally address that. But this one I really liked. It's sort of the chicken and egg question. Does poor sleep hygiene and not enough sleep result in poor health outcomes, or does poor health, like obesity, other risk factors, result in poor sleep? So I don't know who wants to tackle that one, but I thought that was a great question to start off with.
Should I start? I think you'd find that whoever's asking a question, it's actually probably bi-directional, where the same reasons that people sleep poorly contribute to poor health, and poor sleep, as illustrated in those larger epidemiological studies, population surveys, probably contributes to poor sleep. But obviously, it's a difficult study to do. They can only ever, control people's sleep for a short period of time, and not for the length of time that you'd need to see the development of cardiovascular disease. And in some short studies where they have, let's say, healthy volunteers and they, play loud music all night so they can't sleep, or interrupt them every time they try to fall asleep, they can show that their, some of their hormones that control blood glucose, for instance, are out of control, and insulin levels increase. And so there's some, explanation from a biological perspective to explain why poor sleep hygiene might lead to bad health.
All right. So another question, I think also for Marcus. So is snoring a necessary symptom in diagnosing a patient with sleep apnea?
So snoring is very common, a lot more common even than sleep apnea. But surprisingly, there are some people who have sleep apnea who don't snore. Sometimes that's because the sleep apnea is quite mild, but sometimes it can be because the sleep apnea is so severe that people hardly make any noise anymore because all they're doing is choking all night.
Sounds terrible. All right, I'm going to skip over and we're going to go to a question for Dr. Manns. So is leg cramping at night so severe that it wakes somebody up and requires stretching for relief a symptom of restless leg, or is it related to something else?
Well, I suspect that many people here have not had restless legs, but probably everyone has had that leg cramp that just causes agony, and you jump out of bed and you try to stretch it, or it happens during the day. Cramps are common after we've exercised heavily, And exercising heavily is different for everyone. Leg cramping is more common as we age. So elderly people are more likely to get leg cramping. People with kidney problems are more likely to get leg cramping. And here is where medications can play a real role. People on water pills or diuretics, cramping is much more common in people like that. And it's a sign that you're getting too much of that medication. So cramping per se is not a symptom of restless legs, actually. People, again, who are on dialysis often get restless legs and they get cramping. They're different things though. Cramping, interestingly, preventing cramps is not that far off the conservative measures for restless legs. So actually it's really important to stretch the muscles that you cramp. So oftentimes people, it's the same muscles that will cramp on you each night. And so stretching during the day several times to the point where you don't cramp, because you can bring on cramps by stretching as well, but stretching that muscle out in advance, some massage, maybe a partner, or maybe you can massage it yourself, using heat or cold. And then if you're on blood pressure medications or diuretics or water pills, often getting your doctor to adjust the dose of that is helpful, because no one wants to be woken up with cramps.
All right, thank you so much. Okay, so I have a few other questions. So I think Dr. Povis, this is probably more for you. Is an average of 6 hours for a 69-year-old person a healthy amount of sleep? They're active and exercise at least an hour daily.
So the usual questions I ask people, I always ask a question when people ask me a question. It's just a habit of mine. But so the questions you want to ask yourself is, do you sleep in on the weekend? Like, do you find yourself craving sleep when opportunities present themselves? Or let's say if you were on vacation, would you sleep longer? If you answer no to those questions, you're probably sleeping a healthy amount for yourself. Everybody's a little bit different in terms of what their body's drive for sleep is and how much sleep they need and how efficient their sleep is. And so you can be normal and sleep as little as 4 hours. There have been some individuals I've met like that, or you may need 9 or 10 hours and still be normal. But if you're restricting your sleep, that's probably where you need to look at what you're doing.
All right, great. So, all right, so Marcus, this is from Dr. Manns. Is there any funding for CPAP for people with sleep apnea in Alberta?
Good questions. I wish I worked at AHS and I could, if I knew somebody who worked at AHS. No, so right now in the province of Alberta, the funding for CPAP is available for people who are on social assistance. So things like AISH, the Alberta, the assistance for individuals with severe handicaps, people who are on Alberta Works, or seniors over 65 with very low income. And yeah, so most people get their CPAPs covered through secondary benefits from workplace insurance, or end up paying out of pocket.
Right, thanks so much. All right, so there was a kind of general question earlier. So somebody who had been using their Fitbit, but obviously their Fitbit settings sometimes can be a little too sensitive, sometimes can be a little not sensitive enough. So obviously, I mean, most of us have had experience with some sort of sleep watch or Fitbit or activity monitoring device. And if you watch TV, sit down for a movie or whatever, often it will record that you are sleeping when in fact you are not. So this person was asking about how to measure the amount of sleep that they do get rather than, I think, perhaps just relying on their Fitbit.
Yeah, so it's another common question in the clinic. So the Fitbits measure your movement, right? And so if you're not moving, it thinks you're asleep. And this has been studied as a surrogate, as a way to monitor sleep. Now, when we measure sleep in the sleep lab, that's using electroencephalogram, which is like wires glued to your scalp. And so obviously that's not feasible at a consumer level. So movement trackers are probably the most feasible way if you want to monitor your sleep over a longer period of time. That said, the commercial devices tend to be they tend to lack granularity. So either they're too sensitive and tell you you don't sleep at all, or they tell you that you slept for 20 hours because you have a desk job and you haven't gotten up all day. So it's a good way to track trends over time. I wouldn't use it to say, oh, last night I slept 6 hours rather than 7 hours or 8 hours that you thought you slept. What to note from most of these larger studies that I cited, they actually just use patient self-report. They're not using actigraphy. So you're a reasonable judge of your sleep. And so we all do wake up for short periods during the night. We just don't remember it because of, when you fall asleep, you lose some memory for a few minutes prior to that. So to keep you from stressing out about being up all night.
Perfect. And then we are also, after this event, we're going to be sending out I think it was the American Academy of Sciences sleep diary, in addition to some helpful tips on making sure that your sleep environment is conducive to sleeping. So some of those sleep hygiene tips as well. So if you are truly interested in tracking your sleep for some reason, either you want to go see your physician or whatnot, we will be sending out a sleep diary that you can take a look at. And this is something that generally is used in clinic, although if it's something you're just interested in, that's also neat to know as well. All right, so let's see. So again, for Dr. Povis, when does snoring become concerning? And not from personal.
Yeah, so snoring on its own, it's another common question. So snoring on its own is not a health hazard. Snoring with sleep apnea can be a health hazard. I tell patients that snoring is a health hazard if your spouse is gonna put the pillow on your face to make it stop. No, if you're concerned, so things to think about is, are you symptomatic in the daytime? Are you overweight or obese? And do you have risk factors for cardiovascular disease otherwise? In which case it's reasonable to get tested for sleep apnea.
All right, and any tips for older adult night shift workers who aren't able to get enough sleep?
Braden, you want to take that one? That's a difficult question. So the shift work is one of the most difficult disorders. Shift work disorder, excuse me, is a cause of insomnia, and it's one of the most difficult conditions to treat in my experience. And typically as people age, our tolerance for sleep disruption and schedule disruption goes down. And most people who go into shift work once or another are relatively resistant to it to start with. That being said, there have been some studies, things looking at melatonin, timed melatonin, or bright light therapy. So using melatonin to pull your sleep schedule towards evening, and to use bright light to keep yourself awake. That being said, the human body is really built to adjust by about 1 hour per day. That's why you get jet lagged if you travel, if you can remember traveling across different time zone. But yeah, it's very difficult to adapt longer to a bigger shift than that, which is often seen in shift work.
All right, so this a little bit of backstory. This person apparently previously had restless legs when they were a little bit younger. So, but they have an extremely busy brain, and it keeps them from falling asleep or staying asleep, and that's even while using sleep medication. So, any suggestions?
Well, I can start on this one, and then Marcus can chime in. So people do chronically have restless legs. It's interesting. Some patients have restless legs for years and years, but sometimes, and they're not necessarily on any medications. And at certain times it's really bothering them, and other times it isn't bothering them. And is that because of, the stressors that we go through in life? But that's great that you're no longer having that. But I think you, like a lot of people in COVID, or just a lot of people, were plugged into so many devices that our brain never gets a chance to wind down. And that's why you hear talk of mindful meditation and other things to slow things down for you, and that can be helpful. And actually, there's some good studies out there that actually show that can have some benefits for our overall mental health, because we do tend to get so plugged in. And oftentimes we reach for the easy solution, which is, can you prescribe me a sleeping pill, which will help me get to sleep, without sort of addressing the root cause. And then the sleeping pill works wonderfully for a week or two, and then you need a higher dose. And then when that higher dose and that next medication isn't working, then you get sent to Dr. Povis. Dr. Povis, what do you do now? I think you're muted, Marcus.
Now I'm muted. Okay. So I think I'm still muted. Can you guys hear me now?
Nope, you're all good.
Okay. So thank you for the introduction, Braden. So you're spot on that right now we're seeing an explosion of insomnia, and largely driven by stress and how much time we're spending on screens. And so the first step is to address your sleep hygiene. So things like avoiding bright light and avoiding caffeine, avoiding alcohol, and avoiding exercise too close to bed. Other things that are really powerful interventions, scheduling worry time, or using techniques like mindfulness, yoga, things like that during the day to address stress and anxiety. Some of the interventions we do in the sleep clinic, other than medication therapy, there's two things. One is called sleep restriction, the other is called stimulus control, and these form parts of cognitive behavioral therapy for insomnia. And that isn't for everybody. But so sleep restriction, the concept is that if you're sleeping poorly and you spend a lot of time in bed perseverating about sleep, that can actually lead to worse sleep, because sleep itself becomes the cause of your worry. And so usually we recommend to people to restrict their time in bed closer to the amount of time they're actually sleeping, even though the usual response of somebody who's sleeping poorly is actually to spend more time in bed. So that can be something like, even 5 or 6 hours in bed. So the first step for most people with insomnia is to actually go to bed an hour or two later and keep the same wake time, and use that extra time to do your mindfulness and relaxation before bed. So don't sit in front of the television or on your iPad watching Netflix or flipping through Facebook. It's all bad. The other thing I'd give a pitch for is there are some digital services. I keep seeing wait time questions in the chat box. So wait times for cognitive behavioral therapy is long. There aren't a lot of funded services for that. In the sleep center, wait times can get up to a year for that service in particular. And so there is digital cognitive behavioral therapy for insomnia, and there's a group out of Quebec. So there's a couple of notable groups. I'm just looking for the name before I. So in the UK, there's something called Sleepio, which is run by a psychologist whose name is Colin Espy, who's really quite famous. And the other, the program out of Quebec is called Haleo, Haleo. And it's a way that you can get access to digital therapy. Basically, you enter your information and there's a pre-programmed script that gives you feedback as to what to do to improve your sleep. And they also have the opportunity to access a therapist, and the cost is much more modest than in the community where you'd expect to pay, you know, $200 an hour for 6 or 8 sessions.
Perfect, thanks. I may collect those from you afterwards, and we'll send them out with the thank you and the other resources at the end of this. So one last question, and I know this is kind of a big one to end on, but somebody who has healthy lifestyle, so eating healthy, active, no history of hypertension, obesity, diabetes, no smoking, no alcohol use, but has had a diagnosis of sleep apnea since their 40s. So basically, without any comorbidities, why do some people still wind up with these sleep disorders?
Thanks. So,
you know, just an easy one to end on.
Yeah, no, that's an easy one. So I kind of skipped over that slide that I had, but so there's anatomical factors that predispose people to sleep apnea. And the question is, does mild sleep apnea, which I believe this individual indicated, does it matter? Or how to think about that, you know? So the main reason people have sleep apnea is very common, and women be about up to 25% of women, maybe, you know, probably less than that, but somewhere between, let's say, 4 and 25% of women in given study populations would have sleep apnea, and about twice the number of men. And so it's largely just how humans are built. Our airways are disadvantageous, and it does predispose to that risk. And then, so what does sleep apnea matter if you're otherwise healthy? As I alluded to, it's largely severe sleep apnea that's been associated with adverse outcomes for from a health perspective. And even there, it's important to think about it as, if you don't have symptoms, then it's a risk factor rather than necessarily being a disease on its own. And so, similar to cholesterol, which I imagine gets talked about a lot at Lib and Talks, so having a high cholesterol is a risk factor for cardiovascular disease. And so you can take a medication to reduce it, or you can accept that risk. And then mild sleep apnea probably isn't a risk. There have been a number of studies looking at health outcomes in individuals with mild or moderate sleep apnea. The main thing that I tell patients who have that is, you know, keep doing what you're doing in terms of maintaining your weight and your healthy lifestyle, because what it says is that you have the substrate. You know, you have the risk to develop worse sleep apnea if you go and gain 40 pounds, let's say, you know. So I don't know if that's a helpful answer.
I think so. All right, so we are past the hour. So I'm going to thank Dr. Povis and Dr. Manns for giving us their an hour of their evening. Thanks so much for your presentations and all the answers that you had to the questions. I think everybody will agree that they were super helpful and super engaging. And thanks so much to everybody else who participated, who asked some great questions. And hopefully we will see you at some other Live and Moves events. So thank you to everybody again, and have a good evening.
Good night.
Good night. Bye to everybody.
Good night.